that work will give us, oh, you're on this one, you're right. Okay. Yeah, great, thank you.
Rush through this, and this hopefully will be published very shortly. It's been a long route to get this published. Okay, so let me say, we are going to have a treatment within a few years, I bet, and it's based on exciting work that you saw here. And I tell you for sure, there's no chance it would have happened without PXE International and Sharon. So you all should be very grateful for that, and I certainly am. And the other person I will say is Yoni Guido's work really led us down this path. And honestly, we wouldn't have thought of any of the things that we've done without the mouse model that came first. So that's been extraordinary. One of the other great things that Sharon Terry did is, when I started in this, there basically were two people in the country who saw PXE patients. There was a fellow named Ken Neldner, whom some of you may know in Texas, who actually saw over 100 patients, wrote a wonderful book on PXE. And then I was in New York, so they all came to me. It was better to go to New York than Lubbock, Texas. I think by 1990, I had seen over 1,000 patients with PXE. And I actually used to devote a tremendous amount of time, and then managed care came. And Mount Sinai just didn't let me do that anymore. It was, I would spend hours on every patient, and we, if they didn't have insurance, they didn't get billed. And we continue to see a lot of patients, but I was really grateful when Sharon is completely responsible for Howard Berkowitz getting involved in PXE. And he has been a godsend. I don't know that he said this, but he's not just a dermatologist, a very good dermatologist, but he's also an ophthalmologist. So he really has the tools to do every piece, the important pieces of this disease. And last but not least, I was very fortunate to discover Wayne Fuchs, whom I introduced to Sharon, who has been just a godsend to helping our patients with their eye problems. And when we started in this, the average PXE patient was blind by the time they were an adult. And that fortunately has changed because of the development of angiogenesis inhibitors that many of you have gotten. So it's been a real change in the lives of our patients. But we are still out to find the ultimate treatment. So this is where I work. Mount Sinai actually takes care of about half of New York City. Here's the view from my office. And we're going to talk about how we came to the Magnesium Trial. And it started with a patient who had periumbilical around the belly button, pseudoxanthoma elasticum, which is a very common place to get it, who underwent dialysis and couldn't figure out. We actually had other patients who had dialysis, but we couldn't figure out what was it that made the lesions literally disappear. And she, at the time, was getting Amphigel, which is no longer on the market, but was a very strong phosphate binder. It was taken off the market basically because sales weren't enough. And we did a trial which we started with Amphigel and ended up, when it was taken off the market in the middle of the trial, ended up switching to Sevelamer, which you'll see about. Renagel was the brand name of it. And so in that trial, we again started with Amphigel, switched over to Renagel, and we did skin exams, we did eye exams, and actually I don't know if we did even eye exams in that particular study. It was very early, small number of patients. And we did skin biopsies, and it was open label, it was not blinded. Blinded means you don't know which product, you get placebo or the active, and it means you don't know which one the patient got. Here, everyone got the real thing. Half the patients we thought improved clinically, and the 3 that improved, you could see a drop on biopsy in the calcification of elastic fibers. And there was no deterioration of eye disease, but we did not formally follow those patients closely. So based on that, we then did a study using Renagel, which was available, which we had used in the first trial. And patients received 800 milligrams 3 times a day versus placebo. So this time it's a blinded study. That was 1 year, and then the second year everybody got the real drug. And we biopsied patients and examined their skin during that period of time. The main endpoint, because it's so hard to see changes in the skin, the main endpoint was, could we see a reduction in calcified elastic fibers, which is the main problem in PXE? Could we see that on the skin biopsy? And patients underwent eye exams thanks to Dr. Fuchs. In that trial, we had 40 patients, and I will say PXE patients are truly dedicated. 20 patients got the real thing, 20 got the fake, and 90% of them completed the trial. One patient dropped out for a pregnancy, and 3 others just dropped out. You know, probably coming to New York was too much of a hassle for them. We had a complicated rating scale to do the clinical evaluations of the skin, which are again quite difficult. Although when you do them repeatedly, you become quite consistent at it. And so any of you who've been in our trials see our fellows, so they're really good at it because they do it all the time. And they're actually better than me because they're using that scale all the time. So if you showed them a patient and then 6 months later showed them the same patient, you'd get the exact same rating. If you did it to a group of researchers, which we did yesterday, you know, we had this 0 to 9 scale. So I showed the first, which was a clear-cut 8. Any of my fellows would have given it an 8. The numbers rated from 3 to 9 in the group of people here who are not used to doing that. In any case, we do have a scale that is fairly reproducible. And here were the scores on the clinical trial, and this is the placebo group. Why was there an improvement in the placebo group? And by the way, the skin biopsies were done by computer. So in our original trial, you know, so there wasn't room for human error. You can actually easily see the difference between calcified skin and non-calcified skin, and you can quantify it by computer. And you see that the group that got renal gel did a little bit better in that first year, and in the second year. So it did a little bit better. If you look at the proportion of patients who improved, worsened, or remained unchanged, you see that under improved, it was 72% in the placebo group, and this is a clinical assessment, and 83% in the Renagel group. So it's almost the same, a little bit better in the Renagel group. As you look at the computerized image analysis of calcification, the blue is the baseline, and you see a reduction by computer in both groups. And we just couldn't understand it. I'm looking at this and thinking, you know, why would the placebo patients get better? Yeah, we put them on a diet of a low calcium diet, but there was not really any major intervention we did in that placebo group, and I just couldn't understand it. So to the rescue come the mice. So we're not figuring out what's going on here. And then Dr. Guido, who had identified, with the help of PXE International, the gene defect in PXE, created what's called a knockout mouse that you've heard about a little bit this morning. And what they do is they basically get rid of that gene so that the mouse develops features of PXE. So they now have a mouse that has PXE, and they tried Renagel in the mouse. And actually it wasn't Renagel, but it was the chemical, the phosphate binding chemical that was in Renagel. And it did not reduce the calcification of elastic tissue that happens in PXE and happens in these PXE mice. And I was not surprised because we didn't show that much of a difference compared to placebo. He then gave them magnesium. He gave them a high diet of magnesium. I think it was a 5-fold increase in diet, and they did not calcify their elastic fibers. So at that point, we went back, and I did not know that Renagel had magnesium in it. And what I really didn't know is that the placebo had much more magnesium in it than Renagel. He also showed, by the way, that a magnesium-containing phosphate binder did indeed reduce calcification of elastic fibers. So, turns out that, again, we had a fair amount of magnesium in the Renagel, but a ton in the placebo. So that's what led to the study. And incidentally, I'm showing you just before this talk, I cut out all the excess to speed us up. But there are multiple articles showing that magnesium reduces calcification in this mouse model, but also in people. So in mouse models and in people, magnesium preparations have been used to reduce unwanted calcification of the skin or of other tissues. And that's shown here. That's one of the articles. So that led us to our study. And again, it was double-blind, placebo-controlled. And we used magnesium oxide. And a lot of what we did was subject to the FDA intervening heavily because no one had ever used magnesium therapeutically. We had to apply for an FDA license, even though this is in like Tums and Rolaids. We had to get their permission, and they wouldn't let us go to the dose we wanted. I think I showed you that it was 5 times a dose. So it turns out before you get serious side effects from magnesium, which you can get if you go to massive quantities, you get diarrhea. And that was going to be our dose-limiting side effect. The FDA didn't buy that. They said, nope, you can't go above the amount that we ended up giving. Bottom line is we did the double-blind controlled trial. We had 44 patients, counting on a dropout rate of 2 in each. We wanted 20 at the end. They had to have PXE on biopsy. And again, the first year they got 1,000 milligrams of magnesium oxide or placebo, half and half. And the second year, everybody got the magnesium. And we did biopsies at baseline and after the first year, and again after the second year. The first year is the critical year because that's where you actually have compared it in a blinded fashion to a group of patients that got placebo. So, and we used when we say blinded dermatopathologists, they could see, but they didn't know when they looked at the slides to rate the amount of calcium, they didn't know if they were looking at baseline, what time, we had them look at all the slides together, the baseline and the 1 year and the 2 year. And so they didn't know when it was, and they also didn't know if the patient got placebo or magnesium. And you can see how easy it is to distinguish this even visually. Grade 1, there's supposed to be no calcium in normal skin. In PXE, we get calcified elastic fibers, and you see grade 1, there's very little of that brown color. In grade 2, there's a little more. In grade 3, there's a ton of it. So that's how we graded it. And they would look at every biopsy, they'd look at multiple fields and grade each field and then average them. And it went from none to severe, 0 to 3 scale. And we did use the same scale looking at folds of the skin or papules or elevated little yellow pimples or flat yellow lesions and amounts to quantify clinically how much the patient had. And we also did some comprehensive ophthalmologic exams that Dr. Fuchs did. And he'll tell you about that in more detail. Well, actually, he won't, but I'll give you the summary of it. But here's the result, and I'm going to try to make this as simple as I can.
No pointer, and it's hard to see it.
Okay, let me see if is that Michelle? Yes, that's great. Okay, let's just look at these top two because they are the photos from year 1, which was the critical year. And red is the placebo, blue is the magnesium. On these graphs, if you go below the line in the middle, that means you had a loss of magnesium. If you go above the line in the middle, that means you had, a loss of calcium. That means that's what you want. You want to reduce calcification in the skin. If you go above here, you're getting more calcium in the skin, and that you don't want. So those patients theoretically are doing worse. And what you'll notice is there's lots of blue and lots of red on both sides, but there's more red above and more blue below, meaning that the patients who got magnesium did better. And on average, no matter where you took the cutoff, the magnesium patients did better than the placebo patients. So that if you look at 30% reduction in calcification, that occurred in 8 out of the 21 magnesium-treated patients, and 3 out of the 19 placebo-treated patients. A couple of patients dropped out in each group. And that looks like a really big difference, 8 out of 21 versus 3 out of 19. But when you do statistics, if you have a small number of patients, that could just be chance. It could be just luck, sort of, playing the lottery, and you got lucky. So the p-value here is 0.16. To get statistical significance, you need to do a lot better. If we had seen the exact same results in 3 times as many patients, that would be highly statistically significant. But in the 44 patients that we looked at, that was not enough. So you can say that there's a trend in favor of calcium, but you can't say that there's clear-cut evidence that we showed a reduction in calcification of elastic fibers. So the summary was, there were, by the way, no eye changes. And one of the dilemmas with studies of this sort are that you can't do something that's going to hurt a patient. And patients needed to get their injections in the eyes, and we cannot interfere with that just because of the study. So that so the way the study is done is basically you're always doing whatever the patient needs for their good, and so it's very hard to show a difference in ocular findings as a result of that. If we didn't have those injections, then we would have more interpretable results. So there was no effect on progression of eye disease. There was no statistically significant impact on skin progression, but individuals receiving magnesium showed a 3 times reduction of calcium compared to placebo. So, and even though there was 3 times as less calcium compared to placebo, that's not statistically significant. So the potential next steps at the time that I put this slide together is that we would consider a higher dose study or a larger study. But I think the data that you've seen today on pyrophosphate and enzymes that actually can change that are incredibly promising. And so the possibility of oral inorganic pyrophosphate is exciting, and that might be dietary manipulation. You heard about exercise, and I will tell you, every patient who's come to me does get spoken to about which exercises they should and shouldn't do. Boxing is out. And also the possibility of ENPP1 is one of those enzymes you heard about that actually causes an increase in inorganic pyrophosphate. And there is certainly a pharmaceutical company looking at developing that as a therapeutic intervention for PXE. So I am very confident we will have a real treatment in the next few years. I have a lot of thank yous to go around. And in particular, Sharon is on the list and Wayne Fuchs is on the list, but a lot of the rest of the people here are my residents and fellows who, all of whom are really good at seeing PXE. They all know PXE and have done the bulk of the work in these trials. So a big thank you to all of them. And with that, I hope I didn't put you to sleep.
Let's take one question, or they'll put lunch away. Okay, so have your questions ready for the breakouts. What we want people to do, so thank you, Mark. Thanks very much for all that work.